Well, hello, members of the Thriving Urology Practice Facebook group. Did you think I was going to leave you hanging when Mark Painter is going to do a live webinar regarding telemedicine documentation in the era of COVID-19 public health emergency? Heck no. I am hijacking his stream. I'll be sending it to the Thriving Urology Practice Facebook group. Unfortunately, if you have questions, you will not be able to ask during his webinar. But I put the link to the webinar. I announced it yesterday as soon as I found out, and hopefully you all signed up for it. If you're watching this on the replay, certainly leave questions in the comments. I'm sure somebody from the group will be happy to answer them for you. For those of you who don't know me, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for your benefit. This morning, I am taking a short break from the clinic so I can join you all in this webinar with Mark Painter. He is going to be talking about telemedicine, telehealth, documentation in the era of COVID-19 during this public health emergency. He will probably say that for Medicare, you no longer need history or physical examination to arrive at a level for your E&M visit, but for your private payers, it'll be different. I am really looking forward to him discussing further and explaining to everyone the modifiers and the place of service requirements that will be needed. So he is getting ready to go live. Looks like he is on the screen here. So as soon as he starts talking, I'm going to switch on over to Mark Painter. Someone texted me and said they wanted to know what kind of video setup or audio setup that I use, that I think is optimal for telemedicine and telemedicine visits. So we will see if I get a chance to, let me see if I can mute myself, make sure I'm not going over that. So I'm going to, whenever I have time, I'm going to share with you what I use and what I personally think are some of the best practices when it comes to doing web video, telemedicine, or virtual visits. And I shared with you, I think, a couple of days ago about my thoughts regarding the things that you should use. Looks like Mark is about to begin, so I am going to switch on over to the webinar.
Get that set up.
His volume is a little bit low, so I'm going to see if I can do something on my end to boost it.
That all set up now. Sorry about that. We'll go ahead and get started. Welcome to today's broadcast. We're going to talk about how to document telehealth, telemedicine visits, and how to comply with all of the new rules, which of course are changing ever so quickly and ever so slightly. We are hoping that generally we are in a situation right now where we've got the interim final rule, and moving forward, we expect things to be more tweaks than major rule change with at least Medicare. Of course, we're still waiting for all the private sector payers to catch up, but we'll try and give you the best information we can as it is, and of course, provide you updates on the website and as well as through our articles as we get information available. I do want to acknowledge today that I will be using information from CPT, and it is the 2020 version of CPT, and a lot of the information, though the majority of it, is coming from the interim final rule that was released in dealing with the public health emergency. Now, as we go through this, you should have a Q&A button or a Q&A tab below your screen or in your controls. This is the way that we'd like for you to put your questions in. We've got enough attendees that we're not going to unmute anybody. So please put your questions into the Q&A tab, and we'll try and get as many of those answers as possible. We did allow, we hope, for enough time to get through the majority of those questions. Now, to start off, I'm going to talk a little bit about changing vocabulary. The CMS interim final rule made it very clear on a couple of different circumstances in both their overall interim final rule. They still reference everything as telehealth and telemedicine, and you can certainly see a number of definitions out there that use telehealth and telemedicine interchangeably. But in the interim final rule, there were some very specific references within the interim final rule with specific tabs that they addressed, that it's pretty clear that CMS is trying to develop a lexicon to separate what is telehealth, and that is going to now be, and I had referred to that in the past as telemedicine, but we're going to shift that now to Medicare's language. That is synchronous data with live video and audio, which is going to be the bulk of our presentation today. Really, we're talking about how to document those particular visits and what those rules mean in the interim final rule. Now, what we had called telehealth in the past, Medicare has developed this beautiful thing that I'm never going to remember, this communication technology-based services, or CTBS. Guaranteed, this
BS,
is going to take
right.
me a while to change the way I talk about this. Just like those of you have seen me speak before, it took me forever to move to CMS from HCFA, and I continue to struggle with APP versus NPP. So anyway, I will try and use that technology, telehealth again, for synchronous data with live video and audio, which really that second part, that definition of live video and audio, is the most important. And that is really what we're talking about, is the requirements more than anything else. And then CTSB, we may mention briefly, but that'll be probably more frequently in the question and answer session, as we're really trying to focus on documentation of the true telehealth visit. Now, I will end up referring to the public health emergency as the time frame that is designated right now under the 1135 Stafford Act waiver and the coronavirus federal acts that have been enacted. There have been a couple that are addressing this, but in the end, the time frame that we have currently designated doesn't really have a set date as far as the end, unless we're looking at it being somewhere around April 26th. But we are going to see that potentially flux as we move through this environment. So as we go through this, and I said we would focus on some specific rules relative to the interim final rule. And for those of you, I've gotten a number of questions over the past several days asking where they can find the backup for this information that we're going to talk about today and the changes that CMS made relative to the documentation and the level selection during the public health emergency. And it is located in the interim final rule, and I am not going to give you a specific page reference because it depends on which format you've downloaded, but I am going to give you the paragraph and section. It is in paragraph 2, section W. It's called Level Selection for Office/Outpatient E&M Visits when furnished via Medicare Telehealth. So you've got a couple of things in here that this is, in fact, the interim final rule, so we can function off of this. And what they've said very specifically is that they are going to really adopt a partial adoption of the new E&M rules for 2021. Now, they're not going 100% of the way to the new 2021s, and that is because we haven't gotten the CMS or the AMA final release of the CPT book, although we have a lot of that information available to us, and we are going to provide a separate program, and we'll let you know about that at the end of this, where we are going to start the preparation for 2021. And in that, we will talk about the new medical decision making. But essentially, what they're going to do is they say the code level will be selected on either the level of MDM or the total time personally spent by the reporting practitioner on the day of the visit, and that includes face-to-face and non-face-to-face time. They go on to specifically state they are going to finalize this on an interim basis, allowing this to occur during the public health emergency. And specifically, they did this to remove the requirements regarding the documentation of history and or physical exam in the medical record. So we've got a very explicit instructions here that we're hanging our hat on. And this is the backup documentation for those of you who need to find that information. It is in the interim final rule, paragraph 2, section W.
I did a video.
And we are going to provide a link to
already.
those slides. I believe you may have seen that in the chat bar, but we are going to provide a link to this, and we are recording this particular event, and that will be made available as well. All right, so we'll jump in now to the actual documentation and selecting the correct level of service during the public health emergency. So the first thing I'm going to talk about is time. It's a little bit easier to cover, and so time is an option, and we can still select based on codings. So again, this is an either or. You can base your selection of the level on the time, and I'll give you that definition again to just clarify that. Or you can move to the components, which actually means now medical decision making only. So first is time. Time is defined as the time spent by the billing provider for the visit on the E&M encounter on that date of service. I've gotten a lot of questions about, can I include the time that my staff spends dealing with the patient? You cannot include that in the billable time. Obviously, those are things that you can look at as part of it, but as we look at what you now are required to do, or actually probably better to look at what you are not required to do as far as the level selection for the history and physical exam, the time spent by your support staff should be slightly less. Right now, you want to include the time spent by the billing provider, and that can be before the visit, during the visit, and after the visit on that date of service. They have further removed the requirement that over 50% of the time should be spent in counseling and or coordination of care. So essentially what you're going to need to have as documentation to support billing based on time is the total time spent and the relevant medical decision making, relative data that you conveyed. So all the important meat of the event. There isn't really a specific requirement that you say, I spent X number of time before the visit, X number of time or amount of time on the visit, and X amount of time after the visit. You can simply document the time that you spent within the record. There is also no requirement that says the time has to be continuous. So if you spent some time prepping every one of your visits for the day in the morning, then you went through your visits, and then at the end of the day, you spent some additional time finishing up the record, that time, even though it was broken throughout the date, can be counted as the total time, and that's what gets documented in the medical record to support the total time spent and why you're selecting that specific level of service. From a component perspective, the history and physical exam are expected to be limited relative to the medical necessity, relative to what you need to do versus what you need to document. And I think this is why they actually accelerated all of this information for the public health emergency, that the rules that allow us not to document that, because there's information that you need, and you absolutely want to gather that information. And if you have physical exam information that's required and you gather it, you absolutely want to document that information. But it is not now required from the documentation standpoint to actually select the level of service. So document what you actually do, and document what you're medically required to know relative to that visit. But you don't have to go filling out all your templates. And this is one thing that you do want to be careful of as you're providing each one of these visits, because you do want to have a full electronic medical record chart and counter opened and filled out, but you may not want to use your existing templates to run through the history and physical exam. Document what's medically necessary, and then make sure that you're going to you include your assessment and plan, or that part which is relevant to medical decision making. Now, as I mentioned before, the medical decision making guidelines that we're using to select the level of service are based on the current medical decision making guidelines and not on the medical decision making guidelines for 2021. So essentially, we're still going to use the pocket card and wall chart that hopefully many of you still have, but
soon to
we're
be
not going to
collector's
worry
items
about the history and physical. We're just going to focus on medical decision making. Now, when we look at what we've kind of cut up the pocket card, and we are going to go back after the public health emergency and we do still have face-to-face visits that are occurring right now for those patients that need to come in. Those visits are not telehealth visits, so you're still going to need the history and physical and medical decision making, but focusing now solely on those telehealth visits where you don't need the history and physical exam. We're going to be choosing the level of service based on medical decision making or on time. And notice we've blocked out the requirement that over 50% of the visit is required in counseling or coordination of care. So it's the total visit time. And here is the established revised chart right now for the public health emergency for telehealth. When we look at the current definitions of medical decision making, now many of you have compliance programs in place that you've established slightly different counting methodologies. You do want to stick with those methodologies that you have established within your office or are required to follow based on your payer's rules. I'm going to give you the PRS definitions that I think a lot of you are using. So here's what we've got as far as the first piece of this is the number of problems that you're dealing with. Here you want to include the problems that you are addressing that day. And notice I'm using the word problems and not diagnosis. The overall gestalt of the medical decision making as far as the problems that you're dealing with is really based on the problem list and not necessarily the diagnoses. And you can think about BPH, which has several different symptoms that could be used as diagnoses, but in reality, you're treating the problem of BPH as a whole. So it's the number of problems that you're addressing during the visit that day. What you want to talk about, what was discussed, what you're dealing with across the board. And then we give the point system is in place where an established problem, so one that is known to you, that is requiring your active management, or it's a new problem. So those are kind of the two basic categories that problems fall into. They're either new to you or they're ones you've dealt with before. If the problem is established, you know about it, and you're having to actively manage it, or it's getting worse, that problem is worth 2 points. If it is a problem that you've known about and you've got the resolution there and it's going away and you're not actively managing it or intervening to deal with that patient's problem, that problem is worth 1 point. If it's a new problem to you, the problem then gets split into two different categories. One is the problem is actually something that you have all the information available to you and you know how to treat that problem. That falls into the 3-point category. A 4-point problem is a problem that you need more information to actually diagnose and find out what to treat. That may be sending them to the lab for blood work, or if you have it available, imaging centers that you may need to have some things done, or they have to come by the office and drop a urine. All of those things would be additional workup and would come in as a 4-point problem. You can also add the number of problems that you're dealing with on that date. So if you had more than one problem, if both of them were requiring active management, you would obviously add 2 points to get you to the 4-point level. And you'll remember back to the pocket cards and wall charts that the way this all breaks down is that a 4-point problem fits into the level 5, a 3 points gets you a level 3, or excuse me, a level 4, 3 points or 2 points down to a level 3, and 1 point gets you to a 2 or a 1. And the new and established categories have the same requirements relative to medical decision making. So we can talk about levels relative to both the established patient and the new patient visit. So you're going to want to document all of that information. The documentation for the amount of data. This is going to be the information that is reviewed and relevant for that visit and those problems that you are treating that day. You want to make sure that you carefully reference any lab or x-rays that you review. If you do review the images, you want to carefully document that you looked at those images and not just the report. You're going to want to reference any lab tests that you've reviewed and any charts that came from others, as well as information relative to other physicians that may be involved in treatment of that patient. The way this breaks down from a scoring category, and again, this is an area where there is probably more variation than any other, is how you count data within your own compliance programs. So what we count is there is a point for all tests that are ordered in its category grouping. So ordering a laboratory test like a PSA and a UA, both of those fall in those clinical lab tests. The fact that you ordered 2, they're from the same section, that would still only be worth 1 point. An ultrasound and a CAT scan likewise would be 1 point because it's a radiologic test. Both are radiologic tests. If you ordered a UA and a CAT scan, that would be worth 2 points because they are from 2 separate categories. Now, when the information comes back to you and you're dealing with that information or using that information in the course of a visit, you're going to count 1 point for each CPT code of information that you review. So that UA test result, as you're using it to make decisions on how to treat the patient, that would be counted as a single point. A report on an ultrasound would be worth a point. Now, if you do look at the image and the documentation supports that you reviewed the image, you're going to count that as 2 points. So again, just like you would have done in your face-to-face visit, make sure you're clearly documenting all the information that is being utilized to make decisions on how to treat the patient, and include any review of old records or information from other physicians that you're using relative to treating the patient on that particular visit. Finally, the column allows for, the last of the elements involved in medical decision-making is risk. The risk is judged based on the table of risk, and it includes 3 separate categories: the risk from the disease itself, the risk from any management option that you select, or the risk from a diagnostic test that you ordered. This again has not changed. So you can see that a lot of things in that moderate category, which fits into that level 4 service, are the same: prescription drug management, ordering of a cystoscopy, and of course, undiagnosed new problems. If you've got a stable problem and you've got a prescription drug that you're renewing or prescribing something new to, those would be considered prescription drug management. And even though you have one of these categories in the low, you use the highest of the three. So the selection of your code would be based on moderate. So that would be a level 4. Now I'm going to skip back again to my pocket card and wall chart. Notice that medical decision making under today's rules requires only 2 out of the 3 elements. So that means that you can drop the lowest of these and select the level based on the highest 2. So again, if we had a new problem that we knew we were going to treat with medication that date, we would have number of diagnoses would be new, or 3 points would get a level 4, and the prescription drug management would place the risk at a 4, which would also support a level 4 for the billing based on the documentation coding guidelines under the public health emergency. No history or physical exam would be required to be documented, but you do want to, again, document that which is important and relevant to the visit that you collected. Finally, I'll talk about some of the other things that you may want to have in place relative to your evaluation and management documentation. Again, I want to encourage you to think about the fact that you've got your EHR really set up for those in-office visits based on the old documentation guidelines. So you want to be careful of your templates and how you use those. We've had some docs that have built new templates already within their electronic medical record that helps them move through their telehealth visits more quickly. And that is something that if you can do that, you should. You do want to be careful about bringing forward full history or comprehensive history reviews and review of systems if you are not, in fact, reviewing those with your patients. So you don't want to include documentation of things you had not done. The same is true for physical exam requirements. We're not required to do them here, so you may just skip using your physical exam altogether, or you may wish to develop an easy template of things you can observe on video. You do want to keep going with your standard assessment and plan. From the standpoint of treating these differently as your overall encounter, the only things I think you really want to kind of shift around is that history and physical. From a continuity standpoint, you want to keep the patient and yourselves functioning as much as you can like it was an actual office face-to-face encounter, so that when you see the patient again, you know where to find the information relative to that particular patient as you provide that continuity of care. So changing around your templates relative to history and physical is a great idea. But the other part of it is if you can keep your standard assessment and plan in your note, again, to kind of mimic that office visit, you're going to be better off in the long run. And the other thing you want to consider is that as we move out of the public health emergency, the number of people and the positive feedback that we've seen relative to telehealth leads me to believe, and very strongly, that telehealth is going to be here to stay. Now,
100%
I do think
guaranteed.
You should also develop some standard language to include in your chart. This can be dot phrases or however you add these into your electronic medical record. Something that states, and notice I use telemedicine here, but it's hard for me to keep up with everything. But the patient is participating in a telehealth visit. Where is the patient located? the patient has been made aware the visit is remote and that it will be the patient will be charged to the appropriate entity, and that the patient understands and agrees to continue with the with the telehealth visit. And then I also think it's a good idea to add whether or not it is being conducted with both audio and visual, or in fact, the visit was conducted with audio only. Those are the things that you really want to make sure you have documented appropriately in the electronic medical record, in addition to, excuse me, in addition to your standard documentation to support the level of service you charge. Now, we briefly touched on the fact that the evaluation and management codes now are going to be based on a partial adoption of the E&M 2021 guidelines. We are not adopting them fully, and I did not go over those fully. We are going to start the preparation for that. And if you do have some of your time, maybe a little bit slower, although I will tell you that we've talked to a number of physician groups that have really kind of figured this out and dialed this in, and in talking to their patients have been able to convince them to actually move towards the telemedicine visits. But you may still have some extra time because you're not going into the operating room. This may be the perfect time to start preparing for the 2021 change. And to that end, we have and are going to start a live streaming workshop for the 2021 E&M guidelines. We're going to start that now, and we know there may be some tweaks and changes. We've got a great idea of what it's going to happen. So we are updating the pocket card and the wall chart set. If you join us on the 2021 E&M preparation, you will get that new pocket card and wall chart. We are going to have updates on the web that are available after the initial preparations and practice scenarios. And actually, up until Monday of next week, we are running a special on a 2-for-1. And the date of the first webinar is going to be April 24th from 2 to 5 p.m. Eastern Daylight Time. So you will be able to attend, hopefully, from your home or your office. I will be the primary instructor. You will receive an email from us shortly after the Q&A session ends, you'll be able to sign up from that, or you're going to be able to go to the website and use the link to register. All right. Well, thank you, and I'm going to start answering questions now, and I got to move my microphone a little bit so I can see. All right. So we'll start with the questions as they kind of come up to me. So we have one from Brenda. If we are doing audio only and no video, are these billed with 99441 and through 99443 with place of service 02? So so basically there was some very clear instructions included in the interim final rule that when CMS added the 99441 through 99443, that they really intended those codes to address the time that was spent on the phone for those patients who could not figure out the audio and visual. They stated in that they really felt that without the visual, that you couldn't have the same quality of encounter, and really fairly strongly directed everyone to use the 99441 through 43 relative to those audio only visits. The place of service for those that we're looking for, because they're originating from the office, might be and probably should be place of service 11. The place of service 02, as it sits, is going to pay the non-facility fee. That's the way that Medicare processes those claims. The truth is we haven't had a lot of these processed through the system. We've had a couple of folks try with the G2010 the G2012, and had some initial rejections with the place of service 02. Now, Medicare is still getting all of these, and a lot of your private payers are still getting these codes loaded into their system because they weren't in fact live with those codes because they were non-covered. So some of these things are getting rejected because the system isn't programmed yet. Some of them are being rejected on place of service. Now, the place of service was a little bit left in the air, but I think if we use the spirit of the guideline saying use it as if it would have occurred on a face-to-face visit, you're totally justified in using place of service 11, and that is what we are trying at this point in time. Hopefully that answers that question. Next question from Lori. If your patient does not have a smartphone or internet service so you can talk to them via phone only, 15 minutes, can you bill the 99215? Yeah, but I think through the 212 through 215 due to the technical difficulty. Again, I think going back, that Medicare is pretty solid in pushing you to the 99441 through 43 series. A couple of additional things I might add there. If you were able to originally establish a video connection with your patient, and then because of the quality of their internet, you had to switch to audio to finish the visit, I think you've got an argument that if you had enough information in the initial video that gave you that ability to see the patient, you could still potentially use your office visits. But my recommendation to you, if there is no video whatsoever, you should move to the 99441 through 43. There are a few other folks that are relying on the OCR regs and the intent of the rule for continuity of care that are still using the E&M visits for those with Medicare. That's not my recommendation, but just to let you know that some people are. And then the second thing I will add here is that these are Medicare rules. And as we know, the private sector handles things differently. Some of your private payers are, in fact, allowing you to do telephone-only E&M visits. And then the final thing in relations to Lori's question, you should be using place of service 11 and the modifier 95 when you do qualify for a telehealth visit using audio and visual for that evaluation and management encounter. All right, we've got a question from Anonymous. If a doctor is home in a different state than the patient is, can the doctor conduct a telehealth visit per CMS state and commercial payer guidelines?
If you're licensed in that state.
This has been an ongoing question of what about the interstate practice of medicine? Technically, CMS has relaxed the requirements for interstate practice of medicine.
What about your state?
From a federal level. Now, the reality is
malpractice.
that the practice of interstate medicine is truly governed by the states and what the states allow you to do in practicing medicine in their state, though many states have relaxed what they have done. So I would check with, and by the way, the practice of medicine is based on the patient's location, not on the physician's location, primarily. So wherever the patient is when they receive the service, those are the state licensure laws that you want to check. I'm going to encourage you to check with both your Medicare liability care, your medical liability carrier, and with the states and the state regulations to make sure that you're okay to practice across state lines. There are a number of different groups.
Most likely
the
not.
AACM has a .org, has a nice listing of some of the things that have been adopted to change the practice of interstate medicine. The Federation of State Medical Boards has done a number of things to make it easier to obtain a license to practice across state lines. And of course, a lot of the payers are going to allow this under what they're doing. So it's really about making sure that you are appropriate in licensing to provide those services. Now that Medicare, so from Cassandra, now that Medicare covers 99441 through 43, what's the difference between those codes and the G2012? Really, there is very little difference in the way that the rules have been put in place. The G2012 is essentially the same as the 99441, although we do have that one requirement that is patient initiated included in the G2012. So even though Medicare has relaxed those, it's probably easier in most cases for your scheduled visits to use the 99441 through 43, I think, across the board. Another anonymous question: do these criteria of time spent in the recording of prep apply to the 994 telephone visit codes? I'm going to say yes, but I don't have a specific rule backing me up on that. What I'm relying on that for that definition is, number one, the definition of time that was included relative to other evaluation and management codes, and the lack of definition of time relative to anything else. So right now, until we see any further clarification based on what we have, I am going to tell you that you should treat time the same in each case. Include the prep time and include the follow-up time is your total time spent on those telephone-only visits. Okay. Somebody's messing with my questions. All right, so are commercial payers also only needing the medically necessary portion of the H&P like CMS for telehealth, or is that CMS specific? So CMS is the only one that has published those rules. Your Medicare Advantage plans are really instructed to follow Medicare rules. So I feel very comfortable in telling you to use those rules for both Medicare and for Medicare Advantage plans. Outside of that, your private sector payers have the ability to adopt or not adopt those rules. I would look to websites. So far, what we have seen is that United Healthcare and Anthem, Blue Cross or Anthem, as far as major payers, seem to be following Medicare rules as they adopt them, fairly close on the heels of those. Humana, Cigna, and Aetna are tending to adopt a lot of the same rules, but they are taking more time to get there. Your local Blue Cross and Blue Shields are a wild card, unfortunately. So I would encourage you to check the payer websites. As all of you probably well know right now, the payers are slow as molasses. So calling them and waiting online has become very difficult. So check the payer websites and get what information you can off of those websites to see if they are in fact adopting those rules. With a lack of guidance, which is going to happen in a number of different cases, we tend to fall back on Medicare guidelines for our actual approach to appropriate billing. I think you do have a significant amount of support to adopt the new guidelines based on what Medicare is doing and the fact that most payers tend to follow along, and they are using typically the RBRVS or the Medicare RVUs. So with a lack of guidance, I would fall back on the Medicare guidelines to select my E&M codes, meaning go ahead and use the new rules of MDM and time only. Sorry, I clicked the wrong spot. For phone-only visits, do we bill 99215? Well, I think I've answered that question. Mary, hopefully my information has answered your question. Brandon, my hospital only wants us to bill under video visit and not place of an actual code. Should I do both? So I'm assuming that what this means is that your hospital, if you are an on-campus physician, that they are instructing you as an employed physician and billing as an on-campus physician, that they're instructing you to use the G codes instead of the office visit codes. I would probably go back to my hospitals and try and talk to them a little bit, where you may need to use place of service 22 for your on-campus visit location instead of place of service 11. they should be willing to allow you to bill the E&M codes and the modifier 95. That shouldn't affect everything as far as their payments. So that would be my guess as to what they're trying to do here. But again, the facility fee, or not again, the other thing is we did some research specifically on what happens with facility fees that would normally be collected if the visit occurred in that setting. There have been a couple of confusing things that are out there. I could not find anything specific as to what would happen with facility fees because the patient is not actually seen in the facility. That may be that you need to switch to place of service 11 and work something out, but I did not find anything specific. So place of service probably needs to remain the same because your location or your physical location that also is included on the bill has an NPI number and a PTAN, an NPI 2. So they're probably going to have a service mismatch. So my guess is you're going to have to charge the office visit with 95 and the place of service that you would normally use as an on-campus. Hopefully somebody else is finding something differently, and we'll keep everybody posted if we find something new in that regard. If the visit starts with audio and visual, and you're forced to switch with phone, Cassandra, hopefully I answered that I think if you got enough information on the video, I would go ahead with the E&M visit instead of moving to the phone only. Holly, does the doctor need to specify who is present on the call, i.e. is the patient alone and the doctor is alone?
I do.
You know, extra information like that is probably important from the HIPAA side. If you do have, and I'll just give you two things. If you do have somebody in the room with you on your side, so the physician side of the equation, it's probably a good idea to explain to the patient why that person is with you, just for their own comfort.
That's a never for me.
Less for the rules, but to make sure that the patient understands that there's not a HIPAA violation there. And then from the patient side, if they have somebody that's in the room, you probably want to document that the patient has given the appropriate consent to allow the patient to be in the room.
The guest.
A question from Mark. What is the difference between an e-visit and a virtual check-in? So, Mark, I think we're going to look at, so both of those now fall under the new CTBS location. The e-visits or the 99421 through 23 versus the 99441 through 43 and the G2010 and 2012. I'm going to call those the 99421 codes and the codes for the non-physician qualified staff, the G2061 through 63. Those are e-visits. Those are services that are provided through other telecommunications like your patient portal or secure email. They're asynchronous encounters, but you don't actually really talk to the patient. Instead, you use basically a messaging type service that's HIPAA secure. That is an e-visit versus a virtual visit, which right now those are falling into those and I'm going to call them in the CTSB side, those telephone only, which we really talked about G2012 or G2010, as well as now the 99441 through 43. And for your nursing encounters, the 98966 through 68. Now, if you want to talk about, and I'm going to move to the other side, telehealth encounters, those are the visits that you can use your E&M codes with, and those require synchronous audio and visual. Hopefully that gives you that. Andrea, would it be helpful to document the start and end time of screen time for a telehealth visit, or is only the total time spent is relevant? Andrea, we don't have specifics on that, but my recommendation is to document the total time spent. That's all they really care about from the documentation side of things. Lori asked, can an RN bill for G2012 phone call? Lori, that would not be the appropriate code. Those phone calls should be charged under the 98966 through 68. Those are time-based calls for an other qualified health provider, not a physician.
Qualified non-healthcare
switch
provider.
to those 989 codes. And I will say as well, like I mentioned with the 99441 through 43, those were non-covered services, and they may not be set up by your payer. So you may see a rejection in the beginning using those codes, but stay with it. Andrea, how would you recommend documenting time spent for online portal and exchanges? So for those, I would encourage you to have kind of a summary in the visit. And every electronic medical record is very different in how they deal with portal interactions. So a lot of times what we see is portal interactions occur back and forth, and they do end up in the patient's medical record and recorded. So you've got a record of all the transactional issues that are there, but it's hard to find. And so for continuity of care, what we're recommending is you actually take at the end of that exchange encounter, open a regular encounter or some method of incorporating it into the normal patient record, and creating an encounter, including the time spent over those 7 days, and summarizing the transactional the entire encounter that was represented by those number of transactions. All right, so Dr. Gabal, do we still need the modifier 95? So for billing the E&M services alone, the 992.12 through 15 and the 992.01 through 05, those absolutely need the modifier 95 and place of service 11. The 994.1 through 43, the 998.66 through 68, the G2012 and 10, and the G2061 through 63. I would, at this point in time, we're saying don't use modifier 25, but use place of service 11. We've got another question for what about new patients? New patients, basically Medicare completely relaxed the requirement that there is an established relationship with a patient. Go ahead and charge the new patients, the new patient visit codes, and also remember the new rules that do not require the history and physicals. So go ahead based on the medical decision-making or time-based billing. So go ahead with the new patient visits. We've got a comment. My comments have changed, audio versus video. Yes, they have. Unfortunately or fortunately, Medicare continues to adopt new rules, new ways to pay things. So our first recommendations early on were based on the pre-interim final rule information, which was actually sent out through a fact sheet and an FAQ. As Medicare figured out some of the issues that were being addressed or people were having and trying to treat patients, then they actually made some changes. They adopted the 99441 codes where they had not prior to the interim final rule. They changed the place of service recommendations and the modifier recommendations. So unfortunately, they did change. If you do find that you weren't paid appropriately for some of those visits, or you didn't bill for some of those visits appropriately,
rebill. Feel
free to go back and submit corrected claims for those. Please clarify OCR. This is the Office of Civil Rights. The Office of Civil Rights is the group that really is in charge of enforcing some of the rules related to HIPAA and patient interaction violations. And that is where some of the information has come from that is really focused on providing the patient's continuity of care, and where you can find that a lot of overriding language saying, look, we should not let some of these administrative hurdles stand in the way of patient health. And that patient over administration should be the rule of the day. So that's what the OCR is.
Patient over paperwork.
Can I comment on the dramatic charge differential between audio only and traditional office visits? I guess the easy way to say is, yeah, it stinks. It's kind of the way everything was set up. Medicare justified it by stating that you just can't have the same quality of care versus on audio, but we can get pretty close with video and audio. So that's why they decided what they would do. Are the questions and answers going to be included in the information sent after the conclusion of the webinar? They will definitely be included on the recording. I'm not sure that the list of questions will be included, but we'll do our best to do that.
Or you can watch it on the Thriving Urology Practice Facebook group.
In the verbiage in the note, when it says patient was located at blank, are we to say home, work, California? Basically, the intention here was to note where the patient was located as far as a home. I don't think you need to go into address. There is some question that you might want to put state if you're practicing across state lines, that you might say, in their vacation home in Florida, so that you acknowledge that it was practiced across state lines. But generally for most, it would be home would be enough. The 99441 is not patient initiated. That's a question. And the answer is yes. And in fact, the way that they've loosened everything up, even though we still have the verbiage in the codes that says it's patient initiated, that has been so strongly relaxed. I wouldn't worry about the patient initiation as part of whether I would charge the 99441 or the through 43, the 989 codes, or the G codes. Ultimately, you're going to encourage your patients very strongly to access you remotely by whatever means they can. Try and reschedule them. If they can only do audio, if they're a scheduled appointment, go ahead and use the 994 codes. Can we still use history to meet the criteria for certain levels of E&M codes, or are we to rely only on time and MDM? So under the new public health emergency, time and MDM are the ways that you select your final service level. History does not matter. It only needs to be what's medically necessary. So you can't use history and physical to override MDM. Going back to my initial question, thank you for answering. You said phone only 99441 with patient service 11, no modifiers needed. That's the way we're trying it right now. Because we haven't seen much come through on the back end, we may have to amend that, but that's what we're suggesting right now based on the information we have. A question, what is patient initiated? Again, I'm going to state, I don't think that's as important right now. Right now, we're just going to treat those codes as regardless of whether they were patient initiated or not, according to the interim final rule, that those audio only visits and the encounters over the web are billed under the G codes and the 994 codes. What is the difference between imaging studied, reviewed, and imaging studied, viewed? Does simply reviewed means reading the report versus actually looking at the images? So because you get 2 points for reviewing an image versus an actual utilizing the information to make a decision, we are going to, that we have always encouraged you to include that you viewed the image, if you did in fact view the image. The assumption that most of your auditors will make is that you use the report only, not looking at the image. So be specific in adding that you looked at the image or viewed the image and interpret it on your own for that 2 points relative to that. Should we code each televisit as place of service 11s with a 95 for Medicare and commercial payers? So for Medicare, yes. For commercial payers, we've seen the gamut. Place of service 11 with GT or GQ is what some private payers have asked for. Some are asking for 02 with 95 GT, or GQ. So unfortunately, I can't give you a solid answer. I'm going to have to point you to the websites. Again, default, go back to what Medicare has if you don't know any better. But if you can find out what they're going to require, that's going to save you time. Initial office visits, I think I answered that question. I missed the first. Would it be advisable to learn and assimilate all the 2021 guidelines into the telemedicine?
Not now.
No, not at this point in time. The 2021 guidelines, they have not adopted the medical decision making. As we've looked at that, they're still allowing you to use the MDM for 2020. So again, we're going to talk about 2021 in the near future, but right now I would stick with 2020 MDM. What about 99421 through 23? Hopefully I covered that a little bit. Those are those interactions that occur over the internet. Are shared visits allowed for telehealth? So this is a good question. I think with the way things have worked, telehealth visits in which the participation is with both the PA and with the physician should be treated as shared visit. They are encouraged to be billed as if they would have been face-to-face encounters. So if it would have normally been done by under a shared visit, use the place of service and use the rules relative to that shared visit encounter. So I think you can do that at this point in time. Again, not specifically addressed, but it certainly appears that way. To clarify, for telephone only encounters, the 99441 through 43 with price of service 11, not 99241, 99441 should be used in new patients. And for a new patient telemedicine visit, or telehealth visit with audio and visual, use the 99201 through 05. And then for established patients, audio visual 99212 through 15.
Yeah.
Is a modifier required? Again, that a little generic. Hopefully we've answered that relative to each one. Have you received any information on how payers are going to reprocessing claims? We have not yet.
They're probably not going to.
That the payers are work at home and short-staffed, so reprocessing claims may take some time, whereas hopefully they're adjudicating claims in a more automated setting, so they may process initial payments more quickly.
You should resubmit.
Than redos. Would the codes 99441 through 43 apply to an APRN and a PA? Yes, they would.
Qualified healthcare professional.
I don't understand this question. What information on video are you talking about? So hopefully you can put some clarifying in, more information in there. It's probably a little out of context. I'm sure it made sense when you typed it and when I was talking. Advice on the easiest and most efficient way to connect with audio-visual play. Doxy seems to be a little too challenging for some. Haven't figured out how to block patients from calling right back with FaceTime. So a couple of the things we've heard about being used to help patients deal with connections with Doxy and some of these others is to post YouTube videos on your website that you can point your patients to that actually give them video instructions on how to do things. Another thing that we've had folks do with quite a bit of success is actually having your front office, your scheduling staff, try and work with the patient the day before their visit
100%.
to actually run those connections up to see if you can get it worked out.
Definitely
so that
do it.
You don't have this occurring during the actual scheduled time. So do what you can with videos, with instructions, messaging to your patients, discussions with your patients well before the visit. Do you need to reconcile the patient's medications for telehealth visits? So as far as specific information relative to reconciling medications, it's not required, but certainly from a medical necessity side, you may want to do some of that just to make sure you're not prescribing conflicting information. Is the requirement that the visit has to be more than 50% counseling only
Nope.
applicable during the PHE? Yes, and only for telehealth visits? Yes. What CPT
Counseling?
codes for
No.
physical therapy
No,
appointments?
it's
There
the
are
entire
some
visit.
specific
No,
rules
that's wrong.
relative to physical therapy appointments. I will get some information out to you for that, but I don't have those off the top of my head. Could you slow down when you list these codes, or is there a chart for us to see? Yes. Sorry about that. We are trying to cover a lot of information. We're actually past time, and we'll probably try and answer some of these questions at a later date. Actually, we only have a few less, so I'll try and get through those. But we are going to post a list of covered service codes and the modifiers in place of services to our website, so you can start to see those. And actually, I'm getting a flag that we are running towards the end. We've got another piece coming into play. So we will try and pull down the rest of the questions. But if you have questions that were not answered, please go to the PRSnetwork website and join our community. We have a number of discussions going there that are available to you, that we have a lot of shared information and information going back and forth. We have some very active participation from a number of folks. And then we also have information that you can look for to try and get information from the AUA, as well as information available from the Thriving Urology Practice. So there are a number of sites out there that really are putting out great information and trying to keep you up to date. We encourage you to join them all and look for everything you can across the board. Of course, there will be a number of other webinars. We are repeating this webinar again in a week, and we really hope to see many of you on the 24th of April for the preparation for E&M. Thank you all. Stay safe and have a great day.
All right, that's the end of the webinar. I'm going to cover something really quickly. When he said 50% of the visit involved in counseling, coordination of care, I think, I mean, your whole telemedicine visit is counseling, coordination of care. I mean, what else can you do, right? So there's really no 50% requirement, because the whole thing is counseling and coordination of care, and you're literally talking to the patient. You're not doing physical examination or anything like that. So the clarification real quick. I wrote down some notes that I want to cover with everybody. So number one, your E&M visits are going to be driven only by medical decision-making during the COVID-19 public health emergency for Medicare. Now, be aware, this is Medicare, and during the public health emergency, who knows what's going to happen after the emergency is over. So keep that in mind. It is imperative that you understand medical decision-making involves three things: PDR, number of problems, data, the amount of data that you're evaluating or labs that you're ordering or reviewing, and risk. It is important to understand those three sections, and you only need two of these three elements: problem, risk, and data. You only need two to drive your final E&M level during the COVID-19 public health emergency for Medicare patients. Number two, documentation. It's important to document the visit as you do completely and thoroughly for telemedicine visits, e-visits, and everything, just like you do for a real in-person IRL, in real life person encounter. So it is important for you to do that. When it comes to telemedicine virtual visit, consent documentation, obviously it's very difficult for the patient to get a physical, for you to get a physical signature from the patient. So I would recommend that you document with the verbiage. You consider documenting the visit using the verbiage that I've included in the video description. And you can find all this in the Thriving Urology Practice Facebook group. I went through the interim final rule from CMS document 1744 with the specific sections, allowing things or not allowing things as soon as it happened. I did it several days ago, so you can look for the backup documentation if you wish. I also put the link for CMS 1744 IFC in the video description, so if you want to look that up yourself in that 221-page document, feel free, or you can find a video where I discussed it just a few days ago. I went over it point by point and also with screenshots of the actual rules highlighted, so you can take that to your department or whatever to help you guys out. There's some concern about telemedicine, whether or not this is received favorably by the patient. I mean, anecdotally, this is just me. And I've spoken with quite a few of you in private, and all of your patients appear, just like mine, are very, very happy that they can conduct telemedicine. They freaking love it, okay? I like it. And over, I'm seeing that if you are conducting your practice, running your practice efficiently, IRL, you are probably going to do just fine switching over to telemedicine. But if your practice is disorganized, do not have a good workflow when you're seeing patients in real life, that means there's some sort of disorganization. You're going to be screwed going through telemedicine. And I worry most about things that are going to be dropped in closing the care loop. So that is what I really worry about. Not so much the documentation and billing and stuff like that. That's easy. But taking care of the patient, you have to make sure that you have a perfect workflow and nothing falls through the cracks. Okay? Medical legally, you are still responsible despite the COVID-19 public health emergency. Let's see. Mark mentioned that for the 2021 E&M virtual visit webinar, there will be, I'll find a link and I'll put it in the video description as well so you can sign up for it. The first one is April 24th, 2020, apparently from 2 to 5 p.m. Eastern Standard Time to talk about not 2020, not current, but 2021, because that's going to be a huge, huge change when it comes to E&M coding and billing in real life. So that's been talked about for years. It is finally coming out. You can also find more information about that on the AMA's website, American Medical Association's website. This is coming from the AMA that Medicare is adopting, so keep up with it. In 2021, it's a game changer. Some values or some E&M codes are going to go down for some of your visits, some of the problems that you typically see, and some may be more favorable. So keep up with the rules. I can't stress that enough. When it comes to coding and billing, learning the rules is going to be extremely, extremely favorable to you, and I see it over and over again. So from a workflow, from your lifestyle, from your financial perspective, it's imperative that you learn about coding and billing. Let's see. Mark mentioned that audio-only visits during the COVID-19 emergency, public health emergency, for audio-only visits. Audio-only, meaning you just talk to the person on the phone, the Medicare beneficiary on the phone. It should be 99441, 442, 443, using place of service 11. So that's the current recommendation. If you have a partial video and audio synchronous visit, meaning you started the visit using audio and video and things went great and then it cut out, what Mark is suggesting is that if for the majority of your visit you had audio and visual and you were able to garner enough information from the initial video encounter that you consider billing for the visit using 99201 through 5 or 99212 through 5, if that were to happen. So hopefully that makes sense to you. And also place of service 11 for the 9920 and 21X visits. Let's see. Portal, I wrote down portal interactions. When you, there's some question. I mean, first of all, these portal-only e-visit interactions pay very poorly. When appropriate, you should consider converting them to audio and visual. And I find that I get much more meaningful interactions with the patient when I have both audio and visual. When it comes to portal interactions, what he is suggesting is that like, you know, typically the patients are calling you or interacting with you via the portal with a problem, and then you end the problem at the very end, like you're closing the loop for that particular problem that you address back and forth via the portal. At the end of the interaction, typically within a week, you're hopefully closing that interaction, but within a week, at the end of the interaction, it'll be incumbent on the person, whether that is a qualified healthcare professional or a qualified non-healthcare professional, meaning nurses, MAs, support staff, health licensed social worker, whatever in your organization, that person at the end of the encounter would bill a sum of all the time spent for that for that e-visit or what is it called? E-visit. Yeah, it's called the e-visit. That is telephone only or portal only or secure email only. So sum all the time spent to address that particular problem over the last 7 days, create an encounter and do a summary maybe, or address, hey, look at the interaction from this date to that date, and then bill out the e-visit amount. 994 2x 98966, and then the G2061 through 3. Those are the I think those are the portal visit codes. I don't have them quite memorized yet, but we'll see. So that is my take, and that is my suggestion when it comes to the portal visits. Lastly, on the documentation, I personally document the location of the patient, and sometimes I will document. By that I mean the state in which the patient is located. I want to make sure that I am licensed to practice in that state. Okay. And I sometimes will document that the patient's actually at his home in his living room. The patient was in his backyard, showing me the 1 acre lot, right? So I document specifically the location of the patient, the state, and also exact physical location, just for context. That's just me, though. You don't necessarily have to do that, but I'm a little anal retentive when it comes to documentation. What else? And I document that for every telemedicine visit with the patient, that the patient is aware that there's an alternative, that they don't have to do this telemedicine. I give the option of coming into the office for an IRL visit. I document all that with every telemedicine interaction, but it's up to you and your institution and your organization what you like to do. Okay, Mark said that he is going to possibly put his portion of the video out for public review or viewing. This is being streamed live on the Thriving Urology Practice Facebook group. I hope it is coming through on the video live producer. It says that they're having trouble with the video, but it doesn't matter. I'm recording here locally, so I can always publish this on the Thriving Urology Practice Facebook group. If I have permission from Mark, I will put this up on YouTube and share with the world. I think it will be very, very helpful. I'm extremely grateful for PRSnetwork and Mark Painter and his group for always so willing to share information, not just information, but timely information. Instead of having this information come out next week, which is, in my opinion, not fast enough or it's too late, we needed this information like yesterday. And he is gracious enough to give us this free information in a prepared, organized manner to help us all out. So I'm extremely grateful. Hey, lastly, if you guys have any friends who work in urology, please invite them to join the Thriving Urology Practice Facebook group so that we can all collectively learn from each other's wisdom and experience so that we can all benefit. All right. Questions, comments, leave them below. If you are watching this on Facebook, please give me a heart or share this video if you can. If you're watching this on YouTube, give me a thumbs up. Feel free to subscribe and share the video. All right? Take care. Bye-bye.